So without further ado, we'll jump into our first talk by Katie Hampson.
Good morning, everyone. Can you hear me okay? Yeah. Okay, great. It's really nice to be here. It's a little bit emotional, actually. This is the first time I've left Scotland in like 2.5 years. And Matt and Pete have both mentioned, I mean, this conference has actually been a very formative part of my life. The first workshop that I attended, led by Otto somewhere, that was like my first baby steps in learning some R code. So I've come a little bit beyond that now, hopefully, but that was really kind of an aha moment about how we could use, how I could benefit from some of the skills that were being taught at the workshop. So I'm going to tell you a little bit about rabies. Don't think I can go forwards. Okay, so if you're in the US, or basically anywhere, you probably know a fair amount about rabies. It's a pretty charismatic disease, but you might not be aware that it still kills one person every 10 minutes around the world. It was actually 100 years ago that rabies was eliminated from the UK following its reintroduction during World War I. And I think there's kind of a number of points in there that are quite pertinent and that we recognize about the role of reintroduction, times of crisis and response and so on. But that was 100 years ago. And we have 2 incredible vaccines for rabies. One that works in the reservoir, the animal host, and will interrupt transmission. Another that is used prophylactically for someone bitten by a rabid animal, and if it's delivered on time, it's basically 100% effective. And in light of what we know about the development of vaccines for COVID, having a 100% effective vaccine like this is kind of amazing. So you would think rabies wouldn't be a problem anymore, but we also know how inequitable access to vaccines is. And I apologize if some of you have heard this story before, but I want to describe this because it was really impactful for me. So I said one person dies of rabies every 10 minutes. This is Mahando, and you can see the bite on his shoulder. I interviewed him during my PhD. It was about a month after he'd been bitten. And they're quite deep scars. These were actually scars from the bite by his daughter, Mariam, who is 7 years old. Rabies is universally fatal, so at this point, there was no chance of recovery. It was really traumatizing. But this is happening all the time, and every rabies death is horrific. So I've been using contact tracing, and this guy, Magoto, is someone who really was an adoptive father for me in Tanzania as I started out in my PhD, and it was really through his skill and experience that this contact tracing that we started to develop, where we interviewed people like Mahando, where we were able to gather these stories. And we would start off with these very difficult to interpret doctor's records. We would go to particular villages where people had been bitten and would interview them, as you can see here, and get details about the contact with the dog or other animal. So from this contact tracing, I'm just going to give you a few minutes about how we collect the data to begin with using contact tracing and what insights it can give you generally. And this very much feels like a bit of a repeat of all the things that we've learned as we've seen contact tracing for COVID. So we know about the serial interval of infection. We know there's a long incubation period, typically about 3 weeks, but it can last a year. And when the virus starts to replicate in the brain, it changes the animal's behavior, causes them to bite, and that's when they shed the virus in the saliva. And we found through the contact tracing that about half of dogs who were bitten and unvaccinated would go on to develop infection and die. We also learned a lot about access to care and the difficulties in what causes people to be both at risk and to go on to die of rabies. So in this part of Tanzania where a course of post-exposure vaccination costs around $100, about half of people presenting to clinics really are bitten by genuinely rabid animals. And that's because, well, people are already making risk assessments, because if you have to spend $100 to get vaccination and you're bitten by a healthy animal, you're probably not going to do it. But then amongst those that are bitten by genuine rabid dogs, about 20% of people don't get care because the vaccine is so expensive, it's often out of stock, it's difficult for people to reach. And of that 20%, you've basically got a 1 in 5 chance. So 1 in 5 people who don't get the post-exposure vaccination will die of rabies. When we come across a rabid dog, we'd often find a dog after it's been killed by local communities, and we'd take a sample, and we'd go through the process of diagnosis. So the disease is so recognizable that a clinical diagnosis actually works brilliantly. But that doesn't count in official statistics. Any clinical diagnosis just doesn't matter. What matters is the gold standard up on the right-hand side there. That's the fluorescent antibody test. But in Tanzania, there's only one microscope where you can perform this test. And that's pretty much the case across most poor countries in Africa and Asia. There is this rapid diagnostic test, though, and the controversies that have been playing out for COVID have been going on for the last 10 years for rabies is super depressing. I mean, the conversation about individual risk versus population level risk is so relevant here because you don't want to make a decision on a test that is not 100% perfect. And that's not what I would specifically advocate. But the alternative of not using this test is that basically no rabies cases get officially diagnosed because they have to get to their laboratory and get this lab test, which is rarely done. But now we've got these rapid diagnostic tests. One of the other really nice things that we're doing a lot more now of is in-country sequencing. And one of my former PhD students, actually together with Roman, who's another sort of early member of this Eeid community, Kirsten here has been developing these MinION sequencing approaches for rabies, and she obviously had to be turned directly onto COVID at the beginning of 2020. But we've had really nice success with this. So I want to give Kirsten a bit of a plug. Gurdeep, who's now running the show across East Africa, sequencing rabies genomes, and also Kat Campbell, who's done some really fantastic work drawing on the progress made with sort of lineage designation for COVID, and you might have seen her poster earlier. So anyway, that's how we basically collect data and try to make some sense of it. And after 20 years of doing this, I have this graph that represents an enormous amount of effort. These are the rabies cases that we've diagnosed clinically over the last 20 years in this area of Serengeti district, which has a population of 250,000 people and about 60,000 dogs. So although you can see some quite big outbreaks, even in the peak outbreak, less than 1% of the dog population is getting infected and dying of rabies. So this challenges the assumption that susceptible depletion is what's limiting the growth of outbreaks. And this has been something that has been bothering me from starting at this conference 20-odd years ago, because none of the models that we tried worked at all in terms of predicting these dynamics or actually managing to get such low-level incidence. So the rest of the talk, I'm going to basically describe some results from a paper that has been one of those epic papers. We finally managed to get it out after submitting it pre-pandemic, and now I wouldn't say we're post-pandemic, but hopefully we're getting there, that tries to unpick how endemic circulation of this fatal disease can occur at such low levels. So a really key aspect of the data that we discovered from the contact tracing is that you've got this classic heterogeneity that we've heard a lot about in the last couple of days in terms of transmission. And that heterogeneity applies at both the biting behavior of a rabid dog and the movement behavior of a rabid dog. So on average, a rabid dog will bite just under 3 other dogs, and it will typically bite within a few hundred meters of the homestead. But you can see, maybe just about in red, some like dogs that bit 60 plus other dogs while they were infected, and dogs that ran 10, 20 kilometers. And just to illustrate an example of one of these rabid dogs, so these groups of dots represent point locations where rabid dogs bit other domestic dogs in these communities. And you can see in red, there's one dog, the big dot is the source of the rabid dog, and the dots that it went to visit. And you may wonder how we could track this same rabid dog across the landscape. Well, this rabid dog bit 20 plus children during its 2-day foray throughout these different villages. So by the time we were contact tracing, the entire communities knew exactly where this dog had gone to. So you can't always do it like this, but it is quite an effective measure of tracing transmission. And I also just want to illustrate how badly the disease changes animals' behavior. So this is a domestic dog attacking a lion. This is not normal behavior. So breaking this down a little bit, we tried to infer transmission chains of rabies circulation, which we could do either by the contact tracing, where we know direct progenitors and their offspring, as well as statistically inferring based on the movement of rabid dogs. So this work has been very nicely, Malavika here was instrumental in getting this work finished, and was able to show that our contact tracing detected almost 90% of circulating rabies cases, which was very reassuring in terms of giving us confidence about our inference. What you can see from this video is the inferred transmission chains that we had. So we basically saw a couple of hundred introductions from the neighboring districts outside Serengeti over the 14-year period where this data was collected. And each of those transmission chains resulted in clusters of sort of mini outbreaks. The different colors you're seeing here are the 10 largest outbreaks. So the largest outbreaks lasted more than 4 years in these communities, and we detected more than 20 transmission chains that each lasted more than a year in length. So this just illustrates some of these particular highlighted transmission chains. So I'm going to rush through some of this, but we basically built an individual-based model based on the contact tracing that I've just talked about, and we fitted parameters to it. We incorporated vaccination campaigns that were going on in this district, and you can see they're pretty patchy. In some years, they were really good. In a lot of years, they were not so good. This is what a dog vaccination campaign looks like in Serengeti. Many people bring their dogs. It's super fun. Sometimes people work really hard to bring their dogs. Sometimes also people bring their dogs in ways that we wouldn't really advise. But nonetheless, we get people to bring their dogs to these campaigns. So this comes to the question of scale. We were really trying to resolve what was the scale that transmission was occurring at, and whether we could fit this individual-based model across different gridded spatial scales of the landscape. And we essentially fitted the Holling curve as a saturating function to describe the difference between density versus frequency-dependent transmission. So by fitting to the curve, we know that neither of these extremes represent actually what happens on the ground, but maybe we could get a bit closer with this. This is work that was done by Rebecca Mancy. And again, I won't dwell on the fitting really, but we used 2 rounds of approximate Bayesian computation. We were able to pin down and really sort of hone in on the best fitting parameters across these different spatial scales. And then on the second round of ABC, we found that actually the reliability of the epidemics simulated post hoc from the posterior distribution was just much, much better at the 1 kilometer scale than these other scales. And at the 1 kilometer scale, we were seeing predominantly frequency-dependent transmission. But it's a little bit more complicated than that. So this is the density of dogs in Serengeti district, which we laboriously counted during this big census. And you can see there's some places with pretty high densities, like more than a couple of hundred dogs. But actually, half the population lives at a density of less than 17 dogs per square kilometer. So if I switch this Holling curve onto a log scale, you can better see what's going on. Our best fitting model at the 1 kilometer scale, the Holling curve, the functional form of transmission, basically follows the red line. So you can see above the median population density, essentially we've got frequency-dependent transmission, which there's some interesting nuances that I'm happy to talk to people about later. And if you get a chance, you should also speak to Elaine Ferguson, who's looked at the way that human behavior is playing into this, and it's very interesting. But at these lower densities, we do see some density-dependent transmission. So we do see reductions, sufficient reductions to bring R below 1. And the reason, so this is an R0 map of the landscape, but the ways in which susceptibles are depleted is actually occurring in 2 ways. About 70 to 80% of it is from dogs dying of rabies, so actually the density of dogs literally on the landscape being reduced. And also dogs, another 20%, because dogs are actually being re-exposed in these really clustered populations. So if my dog is bitten by your dog, and your dog was bitten by your neighbor's dog, it's very likely that your neighbor's dog also bit my dog. So we have kind of these clustering effects. But the whole point is that these effects are only happening on a very, very small scale, like around a 1 kilometer scale. And that really explains why non-spatial models do a very poor job. Okay, I'm going to go through this a little bit quickly. But the point is, our best fitting models did very well, and we could take different mechanisms of transmission out of the equation to sort of understand the counterfactual. If you assume dog biting behavior is not heterogeneous, you don't have these super spreading rabid dogs, you don't see the large outbreaks that we did observe. And actually, the super spreading behavior can emerge as a property of the model, which was a very nice finding. Also, if you don't have introductions from the neighboring villages, rabies would just go extinct, probably within about 7 years. But actually, the dog populations across northern Tanzania, there's tons of them, it's a very connected landscape, and we're getting these introductions all the time. And if there hadn't been any vaccination going on in the dog population, we'd have probably seen another 50 people dying of rabies over this 14-year period. What I think is really interesting is when we look at the genetic data, you can see 2 divergent lineages of rabies, about 30 years diverged. And they're circulating on this snapshot of a 2-year period, really intermingled amongst one another. And I think the mechanisms that I've described facilitate this. Because if you're a new introduction into an area, unless you land within a kilometer of the nearest rabies case, basically the landscape is really free and easy for you to invade. So these processes facilitate co-circulation of lineages, which potentially is a real opportunity for being able to assess and monitor the impacts of dog vaccination. And that's something we're getting into a bit more now. So just to finish off, I want to highlight some similar work from Pemba Island off the coast of Tanzania, where my PhD student Kennedy has been contact tracing actually for 10 years now. So just to quickly summarize, he spent the first 5 years at a time when a dog vaccination program was just being introduced to the island. Pemba is about the same size as Serengeti, but it only has 4,000 dogs. It's a majority Muslim population. It's hard to imagine how rabies could persist in this population. So we identified 5 circulating transmission chains over the first 5 years, and they were divergent genetically. We know historically Pemba has received plenty of introductions. It's kind of a thoroughfare across the East African coastline. But within just a few years of dog vaccinations being introduced, rabies went extinct, and we were absolutely delighted. And it was super cheap, like $5,000 a year to vaccinate these animals, and we definitely were preventing at least 3 human rabies deaths per year and tens of families being bitten. Our detection probability from the contact tracing was only about 50%, so it was somewhat lower, but still pretty good. And then, towards the end of 2016, we started to see new cases, and we were all pretty devastated about this. And the big question for us was, had rabies always been there, and we just hadn't seen it? Or actually, had the dog vaccinations worked? And the genetic data were really clear-cut on this. There were basically 2 independent introductions from the mainland, and they really took off. We had this big outbreak. Dog vaccination was reinstated, and I'm happy to say we haven't seen any rabies cases since the end of 2018. So it's a great kind of illustration of how quickly it can work if dog vaccination is introduced, but also kind of gives you a bit of humility because you have to keep going if you've got an endemic landscape, even on an isolated island population. So just to sort of summarize, take home, by understanding the process of transmission and the scale of transmission, we were able to, I think, mechanistically unpick what's been going on for rabies. And we know that the scale of transmission, the very local scale of transmission, combined with heterogeneity in both biting and movement, can facilitate this low level of rabies circulation on the landscape. And it's helped us to kind of build models that actually perform well, but it sort of takes us away from the very simple paradigm of homogeneous mixing. The problem is working on these local scale models does require data, and there's not a lot of that out for rabies. So in summary for rabies, we really do need to improve surveillance. And I would really like to see sort of some of the real developments that have been so important for COVID be transferred to something like rabies, and to see dog vaccination implemented at scale, because it's really unforgivable that one person is dying every 10 minutes of a disease like this, when we wouldn't even fathom someone dying of dog-mediated rabies in this country. And this approach, a One Health approach that it's like everyone's talking about One Health now. If we can't do this for rabies, a disease that is killing someone every 10 minutes in communities that we sort of say we want to build capacity in, if we can't do this, like, what hope have we got for really responding effectively in a pandemic? But the point is to build this capacity and to build this access into communities. It does require investment into diseases like rabies, which are not quite as sexy as or don't pose the next pandemic threat. So thank you all for listening. It's been, I really, really want to thank the enormous number of people I've been working with for many years in Tanzania, and collaborators. I get the benefit of standing up here, but there's been an enormous amount of commitment and effort that has generated the science over the last 20 years. So thank you.
Thank you, Katie, for that wonderful talk. I think we do have time for a couple of questions.
Hi, thanks for a great talk. Just sort of thinking about the 2 aspects of these transmission chains, those kind of circular clustered transmission chains and the super spreader events. I wonder if you guys have looked at different vaccination strategies under limited resources, whether it's better to distribute uniformly and cover 50% of dogs in an area everywhere, or do clustered interventions.
That's a great question, because that is the real problem that we're facing, is that the resources are so limited. So you often have a set number of vaccines, and you're tasked with how to use them best. Almost always, the response is to distribute them widely. And there's an equity argument to that. Like at a political level, there are districts and communities that are demanding these. So I see that. But honestly, distributing vaccines like that is pretty useless for rabies. Like because infection is so clustered, you can be vaccinating one community, but not touching where the transmission is occurring. And there's often this reactive vaccination in the same way. And usually that reaction is started when a human case occurs. But by the time you're investigating a human case, it was probably 3 months ago that the dog was rabid. So you've actually got transmission and dispersal of the disease well across the landscape, even if you're focusing on typically just a village where a human case occurred. So what I would say is the automatic response, or is sort of the status quo, is actually pretty disastrous. It's just a waste of money. It's like throwing vaccine without having any effect. So it's challenging, and my thought would be you would want to concentrate it in an area which is as sort of isolated as possible, because once you've got rid of it somewhere, if you don't have introductions, it's not a difficult disease. But the big problem is there just isn't enough investment in vaccines, so it's like watching a bit of a train crash.
Thanks.
Okay.
All right. Thanks so much. So you mentioned that routine surveillance catches only about less than 1% of cases. And I was wondering if you could talk a little bit about what routine surveillance looks like. And then since you had mentioned it at the end, maybe what are some of the changes to routine surveillance that maybe are starting to either be tantalizing or starting to be implemented that's changing that a little bit? Thanks.
Yeah, sure. So you sort of have two styles of country, generally. Countries that do pretty well at human deaths, and they will report the human deaths and then investigate those human deaths, but without really investing in the animal health side of things. So there's very little resources to go out and investigate a biting dog. So typically in many countries, the only animal cases that get seen through routine surveillance is entirely passive and based on the person, either the person who's been bitten or possibly someone in that community either bringing a dead dog to a laboratory or bringing the head of a dead dog to the laboratory. And oftentimes the onus is on them for them to pay for the laboratory test to get done. So understandably, that doesn't happen very often. There's some countries that kind of incentivize it a bit, like if you're confirmed, you get the confirmed case, then you get free post-exposure prophylaxis. But like looking down the sort of poorer and poorer countries, like in some countries, there's just no incentive for that to happen at all. I think one thing that I think is gaining a lot of momentum, but is an implementation challenge now, and I think it's totally achievable, but it's again sort of requiring practical understanding of how things work on the ground in communities. But this thing is called integrated bite case management, and it's based on the idea that if you're presenting to a clinic with a bite where the history of the animal, either the animal has died, the animal is sick with classic signs of rabies, or the animal has disappeared, that immediately puts you in a very high-risk category. So if you go out and investigate that animal, which has often been killed anyway, then there's a high probability that dog will be rabid. And so essentially you're using bite cases, the clinical history of a bite case as a sentinel to find the rabid dog and then do testing that way. And I think if you follow that chain, you can look to increase the percentage of cases that are detected, possibly to above 20%, which would really make a difference. Like if you're looking at a signal from 1%, it's pretty meaningless. But if you're looking at a signal from 20%, actually you can say quite a lot. So that I think has got real legs.
Great. Thank you again, Katie.